Oh, there we go. We've started.
This is our new signature, kind of intro thing. All right. Welcome, everybody, to the Random Anesthesia Topic podcast. I guess Happy New Year, right?
Happy 2025, everybody.
Woo!
Yay!
Clinky, clinky.
I guess we should have popped a bottle of Propofol or something, but anyway. So tonight we have Dr. Ryan Bailey from Premier Veterinary Group in Chicago, Dr. Natasha Bartel from King Animal Hospital in Ontario, and me, I'm Dr. Gianluca Bini from Oklahoma State University, and I have my own consulting company, Safe Pet Anesthesia. Tonight, I guess I'm the one that's supposed to actually choose the random topic. I hope, because I did pick one, but
I mean, don't worry. I've got a lot of backups, so you're good.
I probably this is not going to antagonize anybody, so I don't know if it's going to be as fun. But
well, we can always bring up pizza on crackers again because,
100%. So here's the deal, right? So before I was actually editing one of the past episodes, and I was like, holy cow, my wife was looking at this Chicago hot dog kind of thing, right? And apparently, so you have two different kinds of pickles in it, right? You have the neon green pickle relish in it.
That's a sweet relish.
Whatever, yeah, that.
Yeah.
That relish. And then you have this ginormous wedge of pickle in it, right?
Yep.
So it's basically pickles and buns.
Well, and then there's also pickled sport peppers on there.
Okay.
There are 3 kinds of pickles, each providing a different flavor.
Wow.
But then you say that you
description pickles and buns, because that's really taking this podcast down a whole other trajectory.
All right, so you have a very specific hot dog that you like, right? You said this Vienna
beef. That's like the company. Actually, I had
makes it Viennese.
I had a extern,
and I've been to Vienna many times and lived there as a child, and I don't know anything about this Vienna beef situation, Bailey.
They're a Chicago-based company. I wish I could tell you more about them. I've read about them, but my memory is my brain is just completely blanking on history of Vienna beef hot dogs.
Are you going through andropause?
Most likely, yes.
Everything on
is that why I have the receding hairline? Is that part of andropause?
Yeah, probably. And you have a weird pet duck who's also on the podcast this evening.
Right. What's the thing there?
This is Dr. Quack today. You can see he's got his stethoscope, so he's ready to, listen.
Oh, is he? Wow. I thought he was going to talk about anesthesia quackery.
Oh, hey.
Oh, sound effect.
Is this some self-promotion there, Dr. Bartel?
I was like, yeah, okay. I was like, Beanie, that joke wasn't funny enough for 6 drum rolls, but okay. Yeah, no, that was a good duck joke. But yeah, no, we've got hot dogs, corn sweat. Now we've got guest ducks on the show. Technically, is it not a goose though? Is it a duck?
Yeah, I guess it's more of a goose.
Should I not know this?
It is more of a goose. You're right.
I was like, hold on, I'm a vet and I don't know the difference between a duck and a goose. Like, oh God. Some bird association's probably going to write us a letter.
God, I hope today's random topic is not about bird anesthesia.
I so hope it is.
No.
Please show the way the airflow moves through the bird.
During expiration.
That was for sure a board's question for me, and it was a 100%. Multiple choice, and there were multiple ways the air was flowing between all the air sacs. I just was like, yes.
Move on with your life.
I think I had a whole essay on avian respiratory system stuff, something like that. And it
They love
was
to get us on bird stuff because when you're anesthetizing a bird, I mean, and they're not doing well, I really start to deeply reflect on the pathway of airflow during expiration to try and save their lives.
Oh yeah.
I mean, if they're, and like, if they're getting light or, whatever, I can always deepen them with some meropitin or some shit. Max bearing.
Oh my god. Ooh.
no, I think that, so tonight's topic is kind of debatable, right? So how much thought, how we say that 50% of cats with HCM have HOCM, okay? Now, if you ask the average student, or at least that's my experience when I ask my students,
Side note, why would I ask a student?
most of them have no idea what HOCM is. So how relevant do you think that is? Do you ever think about, oh, okay, this could be one of those? Does it change your plan?
Nope.
I think that's a really
That's it. The episode's done. Bye.
Episode's night, guys. Happy New Year. Nope. No, moving on.
that's
Thanks, Tasha. Appreciate it.
that's such a good question.
Oh, God.
Honestly,
Billy's going to go down his crazy cat path right now, Beanie.
here we go.
And thank God
Get
I'm not
ready. I'm
alcohol.
gonna
Like,
swig this whole martini, and then I'm gonna tell you all about cats. So listen up. But like, for everything we know about HCM in cats, we like us and anesthetists and anesthesiologists, should be seeing way more death under anesthesia because of their wildly uncontrolled sympathetic tone.
oh, Jesus.
And
Lord Almighty.
Oh,
everything says cat with HCM, they develop rapid tachycardia, likely to develop ischemic focus within the heart, and essentially heart attack, death. Always the story of like the cats who die off the needle during their routine spays because they got ketamine. That's why we avoid ketamine. But like, why?
By the way, for the listeners out there, thanks for being here, Laura and Mara. But yeah, guys, HCM is hypertrophic cardiomyopathy, and
Oh yes.
HOCM is hypertrophic obstructive cardiomyopathy.
So you're saying that you have this sympathetic tone that should be really elevated in these cats. Do you think
No,
because
just that cats have a wildly uncontrolled sympathetic tone that is like exacerbated based on some literature from Davis
Oh God,
showing that
time to drink.
some of the opioids increase cats' sympathetic responsiveness under anesthesia, and you've seen it. The cat is asleep. Surgeon does something. Heart rate spikes from 100 to 200, down to 100, up to 200 again, and like it's a known HCM cat, and you're just like.
For the listeners, Ryan was just looking terrified but crossing his fingers at the same time. Which is real state-of-the-art anesthesia over here.
Yeah.
sorry. I got this new sound effect. I really had to use it.
No, I like
It's
it.
a great use.
Yeah, it drowns out the sympathetic lecture. But yeah, no, continue, Ryan. Continue. I want to hear where this is going.
But like, why aren't these cats?
Sorry,
That wasn't
Ryan.
me, but
Sorry.
it was.
I'll stop.
You were like, this may not antagonize anyone, and yet here we are, me on my high horse about cats and sympathetic responsiveness, and how we are maybe negligent in our reaction to it because there's so little. There's one drug that works, and it is constantly written as not to be administered to these HCM cats.
I just would also like to put in this proviso that I am not admitting to any negligence in a legal capacity while we're on this podcast.
Yeah. Oh, yeah. Yeah. Like just as more as the profession writ large, like we don't have an answer for this. Like there is no consensus answer. Cats are not dogs, and they respond quite differently under anesthesia, and it's It
So
is
Ryan, what do you see then? Like if you have a cat under GA who either has known or a high like index of suspicion for hypertrophic cardiomyopathy,
Mhm.
obstructive or not, and you see like a rock and roll sympathetic response to a variety of different nociceptive stimulation, what do? You sweat it out?
For the most part, I ride it out because I know it will calm down, and I know that most of the drugs in my arsenal are potentially going to be dangerous to this particular cat.
Give us an example for the listeners then. Like what kind of drug would you be thinking of and elaborate on your sense of what dangerous would be?
Well, most of our natural reactions, given that us and small animal work so much with dogs, our natural reaction in sympathetic responsiveness is going to be to administer an opioid. It's not right or wrong. It blunts sympathetic responsiveness in dogs all the time. If they don't have heart disease, you could use an alpha 2 as well. But the evidence suggests that the cats, when administered the opioids, are going to develop an exacerbated response to, like an exacerbated sympathetic response. At least that's what some of the evidence that I have read recently discusses.
No, and that's fair, right? I want to go back to your comment about alpha 2, right? So why
Yep.
couldn't you administer an alpha 2 in a cat with HCM?
Because he went to
I
Davis.
No, that is
Sorry, I was
that is a
making a
cardiologist issue. Do
Woo?
we want to get into this? Like,
Yeah, we
seriously?
do. I want
Because
to
100%. This was the
every
sole purpose of that
every
question.
I'm trying to be tactful, but every report says do not administer this, do not administer this, do not administer this.
Yeah,
Like,
but fuck the report, right? That's
oh, I
bullshit. We
oh I
know that.
know. I in clinically, yes, fuck the report. I'm not going to just sit there and ignore it, but at the same time, by ignoring that report, there is a
Yeah,
liability that you open yourself up
100%.
to
100%.
legally.
I'm just going to go out on a slight tangent, a related tangent, but this is definitely a hill I'm going to die on, is that I have virtually negligible interest in a cardiologist's opinion on how I should run anesthesia. And let me tell you why. Their job is not to make anesthetic recommendations. Their job, just like every other specialty, is to report to us on what the pathologies are. And then we are to integrate that and interpret that and then make the most appropriate decisions. So, first of all, I make all my cardiologists scrap that out of their section because they intentionally make me liable for things they know nothing about. And they give these abject statements that really serve a purpose only in general practice. And as a board certified anesthesiologist, they tie my hands. And half the time, they're not appreciating the fact, and I'm going to say this again, if I've not said it 1,000 times, is what happens physiologically under anesthesia is not the same thing that happens in an awake patient. So if you just carte blanche, right, don't use alpha 2s because it may have a heart condition because there's a focal area of thickening in the septum. What the holy fuck? I mean, absolutely not. Am I listening to that? I will make them strike it. And if they don't strike it from the report, you should see the paragraph I write about how the cardiologist is overstepping their lane and intentionally like providing misinformation. So that's how I
Yes,
feel
and
about that. And you know what? The goose agrees with me.
yeah, and I tell everyone I work with when they talk to me, like the cardiologist recommends, and I was like, thank you. I will read what the cardiologist reported about the heart. I will look at their measurements. I will read the text about what they say that they saw, but I'm going to completely ignore their recommendations about anesthesia. I
Because at the end of
understand
the
what they're
day, we would end
for.
up only being able to administer butorphanol and midazolam. And you're like,
Yeah.
there's no nuance, there's no finesse, there's no profound understanding of how physiology is changed by the inhalants or by multimodal piva, tiva, whatever you want to
Mhm.
call that
Yeah.
you're using that day. And it's just ridiculous. Their job is not
Yes.
to tell us what we can and cannot use. Their job is to report the heart disease, stabilize it as best they can, and the rest is the job of the anesthesiologist. I mean, can you imagine a human cardiologist telling a human anesthesiologist how to do their job?
I mean, like all the bypass graphs, they're all on fucking Dexmed. They're all on dexmedetomidine as like MAC reducer, blood pressure support, like slow down the heart rate to prevent
Yeah,
a fucking heart attack under
One of the
anesthesia.
preferred protocols for pulmonic stenosis ballooning is a Dexmed CRI.
absolutely.
Yeah.
The
Yeah.
most
So
published 2023, I think, by Manuel, right? He did a nice study on that.
I saw that.
Oh, Manuel, shout out. He won't
Yeah.
listen to our podcast, but
So, yeah, I mean, I use it too, and I think it's great. I use it for some PDAs as well. Actually, it works pretty well, I think. People are afraid of DexMed, but in reality, with the pathophysiology of HCM under anesthesia, especially if you have HOCM, DexMed is actually a really legit choice.
of course it
I
is.
intentionally put them on DexMed CRIs. Like it works amazing. Now, I do agree with you that, the liability part sucks, right? Like, if the cardiologist put it in the report,
Have them strike it from the report or put your own disclaimer in your own medical records saying that the cardiologist should not be making anesthetic recommendations, and actually that makes them liable right in return. So you can get them back. They will march to the beat if you know how to push their buttons. But I mean, that'd be the same thing. Like that'd be like if I were doing, I don't know, like anesthesia for gut biopsies, the internist is in the room telling me what to do for anesthesia. Like, here's a newsflash. If you can do it better than I can, I encourage you to do so. And I'll go on lunch.
Yeah.
Liquid lunch. Mm-hmm. But yeah, the job of the other specialties, just as a nutshell, is to report all of the abnormalities and to stabilize those diseases as best they can, given whatever relevant time frame. But it is the job of the anesthesiologist to integrate that information and design an appropriate protocol. I do not need to take anesthesia tips from somebody who has not anesthetized a patient in 12 fucking years.
Oh yeah.
Right? Like, give me a break.
The thing that brings up though is like, we all sit here and we're like, in humans, a lot of humans with various different types of heart disease are being put on like dexmedetomidine CRIs of some variety in humans. And yes, humans are not cats are not humans, et cetera, all of those caveats. But like, I feel like there's just a paucity of research in like dexmedetomidine based protocols for these kinds of cats, like.
Well, that's because what Beanie said, everyone has this inappropriate phobia or hesitancy towards certain classes of drugs, which sometimes is cultivated straight out of the academic institutions or taken totally over the top by other specialists. Like, I never give more than 0.1 mg per kg of methadone. And it's like, okay. Yeah, like go back to sewing.
Where did that came from?
But yeah, but it's totally like we should not. There was a great editorial a few years ago that I read. I think it was the British Journal of Anesthesiology. And they basically said, like, it's totally inappropriate to have drugs that you like or you don't like. Like, all drugs have advantages. All drugs have disadvantages. All drugs have uses. And at the same time, you could probably use almost every one of our drugs in almost every clinical scenario, and you would still do well as long as you have the capacity to understand A, the physiology, and B, the pharmacology. And that's honestly exactly how I feel and how I practice. Like, yeah, I have minor preferences, and then I actually have evidence about things that don't work. But at the same time, I'm totally like, you can probably appropriately use most of those drugs. And when we get these carte blanche, like thou shalt not use dexmedetomidine in cardiac compromise, you know what that is? It's lazy. It's lazy and it's stupid. Right. Yeah. And what you're doing is you're not benefiting a patient in a way that may actually increase not only survivability to recovery, but survivability to discharge. And that's nobody's business but ours. So.
Sure. Yeah.
I'm going to rock up to oncology and be like, do you think that LCHOP protocol is the most appropriate protocol? Maybe you should consider this protocol. Like, like that one time that I once gave steroids to something with lymphoma, this is what happened. And therefore, I almost was an oncologist. Like, how many times I've heard people say, oh, I thought I was going to do an anesthesia residency. And I'm like, you know what? It's funny because I did one. I'm board certified. Like, I'm like, please don't call yourself a soldier unless you've been to war. Like, it really chafes my butter.
Okay. Tonight we totally triggered you. This is
well done. We started with something really benign like HCM or HOCM. The original question being, do I really tease out the subtle difference between obstructive and less obstructive HCM. And I stand by my original answer, which is nope.
No.
Yep. I mean, yeah.
Yeah. So
Yeah.
I do
And like,
Dexmed for all of them. Like I don't care. I mean, the heart is totally fine to like sustain that increase in afterload. Who cares? You know, in reality. And the
I mean,
whole benefit.
everything says Dexmed is like all the the pathophysiology and everything we know, like hypertrophic cardiomyopathy and almost every single cardiomyopathy cats get falls into the larger category of diastolic dysfunction. And taking from the human side, diastolic dysfunction is always treated with normal to slightly increased vascular tone and normal to slightly low heart rate, because we want to promote like slow heart rates, increased diastole, increased diastolic filling, increased perfusion to the myocardium. The slight increase in afterload is going to slow that heart rate down. It's going to help out. These are thick ass hearts. They can pump. Like these hearts can pump. You know what I mean? Like their fractional shortening is like 110, or like their fractional shortening ejection fraction is like 110%. They're like, that chamber is nothing by the time that heart's done squeezing.
Oh, that's a good point, Bill. I never thought about it too. Like they actually have like more myocardium, potentially more potent contraction.
Yeah.
So in the face of a lower heart rate, they're still going to maintain appropriate cardiac output.
Yeah, like every time I look at the echo report, if I see a low like fractional shortening EF, I'm like, ooh, this cat's heart is in trouble. Like they should always be hyperdynamic. They should always be 80s, 90s,
Yeah.
like fractional shortening ejection fraction, because that heart is so thick and that chamber size is so small. They should really be knocking it out of the park every beat.
I like that. I
Yeah.
like that.
Yeah.
Did you guys recently do that survey on whether or not you could visually assess fractional shortening?
I did not. I am not a wizard with the probe. I have not done much ultrasound for
Oh,
heart
you
stuff
don't
and
need
like
to be a
GI stuff.
transesophageal probe pro to do the quiz slash by Manuel, who won't be listening. But yeah, no, it's actually quite interesting because they do. I mean, he gives you some extreme cases, and it actually, like from a baseline point of view, would be a good jump off point to be able to start to assess. You know what? Guys? I just had a fucking revelation after years of being told how to do anesthesia by cardiologists. I'm going to subspecialize in transesophageal echocardiology, and I'm going to start telling cardiologists how to do their job.
So actually, that was like a whole discussion during AVA this year, was cardiothoracic anesthesia, and like cardiothoracic anesthesia is emerging veterinary specialty,
Yeah.
but it was also a talk from a human cardiothoracic anesthesiologist. And a lot of his talk was about like how initially a lot of the cardiothoracic anesthesia people were learning like esophageal, like transesophageal echo, and they were doing all the views and this and that. And then like that became its own thing of like the anesthesiologist like working the like TEE probe the whole time.
Yeah, in
And now
human
it's like,
medicine, you do a fellowship in it, and then that's basically your shtick, right? Like
exactly. And now
you
it's
come
like
in and
moving back the other way, and like the anesthesiologists are doing other things now. And like, yeah, it was a interesting discussion.
Do
About
you do you use pitted olives for your martini?
No, I like to eat the whole olive, and I don't need to be. I'll be honest. I love a non-pit olive. These are a lovely Castelvetrano pitted.
What kind of martini are you having? Are you having a true classic, or is it dirty, or what's happening over there?
This was a martini from a company that started in Chicago, and it's made in.
Are you on that like board of Chicago tourism? Like,
I wish,
He's
man.
getting
I
paid.
wish. But
yeah,
this
like
is made with
everything
like
that
a
you say,
bar.
like pizza, martinis, all of those are Italian, and like Beanie's just like biding his time over here on the
Yeah,
left side of my screen, and you're like Chicago, Chicago.
this is a martini from a bar in Chicago, and it's gin and vermouth, obviously, as a martini
Obviously.
is, and then it's got a little yuzu spritzer right
Mhm.
over here, and then yeah, it's pretty good. It's like a pre-made martini. I just keep in the freezer, pull it out, a couple ounces. I mean, I can make my own, but
I like
this
the
is so
yuzu
easy.
spritzer. I mean, sometimes I just use one of those to freshen up at the clinic so I smell nice and citrusy, but
Yeah,
I guess it works in a martini too. It's not just for smelly vets.
it's a bougie martini. It tastes really good. We won
Interesting.
it at a silent auction.
Now, how would you feel if somebody said, if you were like, let's say you were a bartender, Bailey,
Oh God,
and someone came up
I'd
and
be
said,
terrible.
Beanie, hold on to your pants here. And like you came up to the bar, and like I came up to the bar and I said, I'll have a vodka martini. Just
I mean, I wouldn't say anything because if that's what they want, I'm
uh-huh.
more than happy to serve them what they want.
Well, what do you think on the inside? What are you in the duck?
And and my wife loves a vodka martini 50-50 with
You may have to edit this part of the podcast
yeah.
out, Beanie.
She loves a vodka martini. And I will say there used to be a bar in Chicago. I think it's closed. It's definitely closed because it used to be near our house and it's closed. And they did a shaken vodka martini and like I have never drank a drink that tastes so cold in my entire life. And as a person who, drinks ice, you can't see the ice in there, but there's like a ton of ice in this cup. As someone who drinks all their drinks ice cold, I was like, this drink is insane. It tastes like I'm drinking the coldest water alive. So
What's
yeah,
What's the
corn
deal
sweat
with
mug, by the way? Like, do you have a second martini going? Like, what's happening over here?
well, this is just water. This is just water and ice, and then
It's
this
corn sweat
martini.
on ice, and that's your
This is
that's
martini.
a
done, and now
corn
I've got
sweat?
olive seed. Now I've
You should
got
invent a cocktail called corn sweat,
not a bad idea.
right?
More for summertime.
Excuse me.
I'll work on it.
And you could tell everybody, obviously, it's from Chicago because you work for the Board of Tourism.
Sure. I
Yeah.
mean, if I make it, it's from Chicago, isn't it?
Does the
Isn't there
goose
a
have little
drink?
Chicago outfits? Like, does it have a Bears outfit and a White Sox
Duck,
outfit?
not yet. He has a hot dog. The goose, I mean. I always call him the duck, the goose. He has a hot dog.
I think you should qualify that as he has a hot dog outfit because
Yes.
nobody wants to know about
Don't
your
they,
goose's
don't they
hot
even
dog.
sell those cocktail hot dogs? Those little,
Those are
right?
Vienna sausages, which P.S. never seen one in Vienna.
Yeah, I'm sure. I've not. I mean, I've had cocktail weenies, little smokies from Hillshire
Yeah,
Farms. I used to
those
love those
little.
things.
If you serve
You
those to a
love those?
person from Vienna, they would probably flick you in the middle of your forehead. Like there's
Oh, I'm
zero
sure.
chance.
Oh, I'm sure.
Yeah.
Holy shit!
I mean, people keep branding stuff as being like Vienna this and Vienna that. And I'm like, have you been to Vienna? Like, no.
Apparently, I didn't know this, but I heard or read that there is a counter at the Vienna airport for people that flew in and thought that they were in Australia.
That's not true.
Okay.
However, I will tell you this that when we lived in Austria when I was a young child, my parents would get mail that had gone through Australia and had been redirected. Yeah.
Really?
Yeah. And sometimes too, like I have throughout my whole life, I'd be like, oh, my dad's from Austria. And people will be like, oh, and they'll start being like, throw the shrimp on the barbie and like talking about kangaroos. So in Vienna, you can actually buy a shirt that says no kangaroos in Austria. Because that is also a common but there's no airport booth, but there should be, and you should get a free kangaroo shirt, I think. But yeah, no, it's I never figure out why people have never heard of Austria due to its, significant 20th century contributions. But I'm talking about Freud. Everybody relax. But but yeah, no,
I was more thinking about the mother bowls, but that's about it.
Well, that's because you're European and sophisticated, Beanie. But yeah. But
I'm
anyway,
gonna ship you a mother bowl, Bailey, next time.
should be a what?
A Mozart bowl?
Oh, a Mozart ball.
Mozart.
Yes.
Oh, so fancy.
Never
Yeah,
heard
Jeez.
of
they
those.
serve all those Vienna sausages, not. So should we
Just
talk about anesthesia? I have a question I
Yes.
want to ask you guys.
go
Yeah.
for it.
Hit me.
How do you feel about gabapentin for acute pain?
Okay, we went over this like 3 times
I
in
just,
4 episodes.
I mean, we've gone over Dexmed a few times too, but yeah, no, gabapentin and acute pain. Discuss. Chickpeas are neither chicks nor peas. Discuss.
I mean, like I don't think the research is out there, right? Like clinically it doesn't work. But
Yeah.
like I will say I have been approached about setting up a study to really kind of tease that out. And I gave some guidance as to like how I would try to set that up to the best of my ability
And which was?
with some other people. Well, we were discussing like caseload and like, in a private practice, I was like, I think you have to use TPLOs just because you have access to so many. And you would set up a control group where one gets standard protocol of like NSAIDs and the other, instead of NSAIDs, gets gabapentin. I mean, I think there's a lot of confounding factors though, and I, point that out because you're going to have to standardize the anesthesia protocols if you can, standardize nerve block, epidural. Do you choose only systemic drugs? I mean, I don't think that's appropriate. Like I want to see the research. I want it to get out there. I don't think we have it yet, but I think to me it's a no. Like I strongly suggest we come up with an alternative option for those cases. I know why I know why we want it. I know we want it because it's safe and we label it as a safe, no renal disease, no GI ulceration. Like we need to take a fucking chill pill. That I'm sorry, like we have to take a chill pill on GI ulceration. Like, come on. I say to me it's a no. It's a no from me, dog. And
Beanie?
Yeah, no. I think it's a no for everybody. Really,
Here's
it's
a
good for
question.
sedation,
I'm
but
going to
that's
give you a
about it.
scenario. So let's say you have like a young, healthy dog who acutely like has a CCL rupture. Okay, so
Mhm.
and then comes in, and
But time out. That dog doesn't have an acute CCL rupture. We all know that.
okay, fine. So finally has its complete tear after limping around on its partial tear.
So it has chronic pain.
Yeah, so it has some degree of chronic pain. Now,
So gabapentin is the appropriate choice.
I'm gonna punch you in. I'm gonna punch you in the goose in a minute. Let me finish the fucking story. Don't you back him up with his bullshit, Beanie. I will beat you.
That's Dr. Bailey.
That's about the level of stethoscope you deserve. So let's say you have a dog who comes in with like mild to moderate. You know who's going to get a gastric ulcer shortly? It's going to be fucking me. But anyway, so what if you have a like healthy dog who comes in with some mild to moderate knee pain, and then we put it through a TPLO procedure, whatever they do, TTAs, extracapular. I don't give two flying, you know what's. And then the dog wakes up for maybe like a 3 out of 10 pain at like 9, 10 out of 10 pain. Are you going to chart gabapentin for that?
No.
Beanie?
No.
Me either. And how often does gabapentin get charted by the surgeons? 100%.
Because why are we so scared?
The reason why is the same as why the cardiologist shouldn't put an anesthesia blurb in the report. It's because that's not their job.
Maybe we need to prescribe an NSAID at every instance we can. Gabapentin is really not so useful for acute pain and, trying to educate the whole hospital.
So useful, Bailey, or useful at all?
I mean, I think so, like, having done some time with the human chronic pain side, like the human beings who experience chronic pain, I think gabapentin is hit or miss. Humans, some people swear to God that they started gabapentin and their lives were different. They
Yep.
say it absolutely changed my life for the better. I am a different person because of gabapentin. And some humans are like, I absolutely hated gabapentin. It was like I was in a fog. I didn't really understand what was going on. It did nothing for my pain, blah, blah. And to my mind, that is probably the experience our pets have when they are on gabapentin. There are probably some dogs who you put them on gabapentin and their world is different. They are more comfortable, they feel better, and there are probably some dogs who go on it and it doesn't work. And how do we predict that? That's a great question. That is where we need to do better chronic, pain management, like questionnaires, or like we need a Glasgow scale for chronic pain that's like validated across, the board
Yeah.
or whatever. But
which is
like,
going to be extremely hard to get. Like even research-wise, it's really hard to design those. And
and
especially with the caseloads we have,
yeah,
you know, the biggest
yeah,
hospital, they roll like probably like 3 to 5,000 anesthesia cases a year, maybe.
yeah.
It's tiny compared to what they can do in humans.
So I don't think gabapentin's a magic bullet, and I don't think we need. I think we do overprescribe it for sure. I think that comes from a fear of side effects of the other analgesic drugs. I don't think that's appropriate, but I do think I don't like, to our point earlier, I like and I don't like certain drugs. That's not a good way to view these things. I think there's a place for gabapentin for some subsets of patients. It's just, what are those and how do we find those? That's a great question. And I think it's just an individual thing. And like, I wish we could talk to dogs, or cats.
Yeah,
Mostly cats.
Mostly
that'd be
cats.
nice.
I was like,
That'd
I'm
be
sure whatever a
nice.
dog has to say is
So,
not nearly as interesting as what a cat would.
but going back to our original question before we diverted on like wieners and
Martinis.
fucking gabapentin, what's your normal protocol for a cat with HCM that is not in heart failure or that's in a mild to moderate HCM?
40 mgs per kg ketamine.
And that's how you kill it. But if you actually wanted,
Side note, I'm
if
just kidding.
Martel's just trying to get her day over with. If she gives them that much, all the cases go lickety split. You know what I mean?
Yeah, I can go home and drink tea.
if you want to keep the cat alive, I should have specified.
Right. Yeah.
If you wanted to keep it alive,
Yeah, be clear about your
what's
strategic plan.
Yeah.
Like,
Yeah.
if I want to keep the cat alive, what kind of procedure are we doing? Painful or non-painful?
let's say you're doing a fracture in a cat. Whatever.
Well, I don't know. Bailey laughed, and I don't know why I'm laughing in return, but okay.
Last time you get a fracture in a cat.
If I have a better one, do it. Like, I don't know.
Balcony fall, right? So maybe you're fixing one
Let's
fracture.
do it today. I anesthetize a cat, maybe with HCM based on the echo, and it was pretty equivocal.
Well, what did you use?
So for me, I was already on methadone. I repeated the methadone dose. Induction with alfaxalone and diazepam.
Did it upregulate the cat's sympathetic tone?
It not so much, actually. It was a little surprising. I did have a discussion with the anesthetist that this cat may or may not have HCM based on the report from 2021. The current year when this case was anesthetized is 2024.
3 years later. So, question for you: why did you pick alfaxalone?
I personally really like.
Jesus, do better.
I think the induction quality of alfaxalone in cats is just so reliable, and it's so rapid. They get deep quickly, and it has a really nice intubation condition. I think better than
Beanie, it's because he's using Chicago alfaxalone.
Yeah, exactly.
Yeah,
oh my God.
No, because my alfaxalone is not this awesome. Wait.
But we did say your goal for HCM, right?
Yes.
You need to lower your heart rate.
I know what's
coming. I know where you're going. And
but alfaxalone, we do know, for whoever is listening that doesn't know, is that at times it may increase heart rate.
Yes.
Right.
Yeah.
So why would you do that?
Yeah, Bailey, why would you?
I like to live on the edge. I'm trying to go home and drink tea. For me, it's because it gives me such a nice quality induction, and it's really rapid. This cat, we were able to get away with 3 milligrams of alfaxalone, and that was it.
You can get away with 2 mg of propofol too.
I can get away with less than that. So my protocol, if anyone cares,
it worked great for the record, and the cat did have a little sympathetic responsiveness. I did not.
Is the cat still alive?
It sure is. The highest the heart rate got was 130. But I did have a whole discussion about how, and I don't, again, cats are just strange creatures. He was sitting with a heart rate of 100 to 110 at induction, after induction and in prep. We got into the OR and I had a whole discussion about cats and their sympathetic responsiveness, and we need to be mindful and watch it and kind of see, what they do, because not every cat does it. Not every cat goes, skyrocketing. And the cat was normotensive the entire time, and the echo report was quite a while ago, and the cat's never been rechecked. He does have a heart murmur. Did have a heart murmur. Does, I guess. I guess he did during my auscultation, but I don't know if it's still there. Like, we all know cats can throw murmurs like
That's true.
crazy.
For whoever is listening, you may have cats with heart murmur that have HCM. You may have cats with heart murmur and no heart disease. You can have cats with no murmur and heart disease. So
Yeah.
cats are random creatures.
Oh my God, I know.
Well, if I
Which
were
is
to
funny.
anesthetize the same case, I would have done,
Yeah.
my pre-med would have been methadone, dexmed, and I would have induced with propofol midazolam. And then I would have blocked whatever I could block, and I would have lived my best life and gone home for tea.
Yep. And this cat did great. Like, this cat was one of the most stable and not super responsive cats. And I don't know why they're like that. It's like when I was a resident and they were discussing cats and some of the research they did on cats and how, like, they did, nitrous oxide and fentanyl as, like, macroducers. And, like, well, in one population, it reduced it, and then we crossed them over, and then the patients who got reduction didn't get reduction the next time. And
Whatever happened to nitrous oxide? Like,
it's a big greenhouse gas emitter.
but
no, I get that you did use it, but do you
I used it when I was a
now?
student, and I still use it when I was a resident.
But now you don't.
I don't have we don't have the piping for it.
Yeah.
Thank God. Okay, good.
It's also controlled, isn't it?
Not here in Canada, but no, it was extremely effective. It's analgesic, and it would provide cardiovascular stability, and yeah, no, it was great. It was great.
Yes,
If
make sure
the
you don't
patient can handle a reduced inspired fraction of oxygen, then nitrous was. It's kind of like, oh God, I'm becoming one of those old anesthesiologists, like the ones who still talk about how great thiopental was, like you always like, why did we get rid of thiopental? Oh.
Tell us about halothane.
That's why I wore this sweater. It's a shout out to halothane.
Tell how you used to smoke cigarettes in the OR, but you had to keep your hands low so you didn't spark the halothane.
Guys, stop. I used to hold ether down just in front of the horse's face and just like basket muzzle it to like the ground. Like, yeah. No, I'm kidding. Beanie, relax.
That's why they had the chains on all the chairs at Davis so they wouldn't spark the agents.
Really? Are you sure it wasn't because when the bag and barrel exploded, it didn't kill you in the room? Yeah.
I've never I love the bag in a barrel thing. It was one of the most entertaining pieces of
sure. I could also build an anesthesia machine and ventilator out of shit in my dad's garage. But I could also buy something really nice from, Data Omida or like GE and like get on with my day. Like, yeah. I'm not one of those people who like, let's run. Bailey, when he wants to peep, he runs his piping through a fucking bucket of water. Like,
I did that one time because I was at a clinic who didn't have a peep valve, and the dog was desaturating in front of me with pulmonary hypertension, and I was like, I have to do something. And I did learn that if you stick the exhaust hose through a water bucket, it will create positive end expiratory pressure.
You thought I was kidding. You thought I was kidding, but he's actually done it.
If you actually measure the centimeters of water, that's actually the pressure you get, right?
Yeah.
That's how it works. Like literally, that's how it fucking works.
Yeah.
Right.
Yeah. Yeah. I mean, honestly, I don't want to break anybody's hearts, but you literally could build like an anesthesia circuit at home and a ventilator at home for sure. I mean, dress them up in $80,000 outfits with computer chips, but at the end of the day.
So Bartel, this cat you're anesthetizing, how much Dexmed are you giving? Are you putting him on a Dexmed CRI?
I am now, just to fucking mix it up.
How much?
I guess here's my question, which is irritating, but relevant, was my pre-med IM or IV? Now, in my world, almost everything is IV because I hate
Give
IV
me both.
injections.
Give me both.
Yeah, so I would say and is the cat fractious or not? But I'm probably going to give that cat, I'm going to assume I have a catheter, and I'm going to assume the cat is just like a fairly like anxious but normal cat. So like the huge.
Yeah.
2 to 3 mics per kg IV.
Okay. And
Yeah.
then are you
With
putting
my
him on an
methadone?
infusion during the case?
Sure, why not? Let's
say you're doing an abdominal procedure. Which block are you choosing?
tap.
Okay. So we know that the tap doesn't cover any internal organs. So the cat's still going to deal with some degree of sympathetic responsiveness when the surgeon goes pulling around in there.
And visceral pain.
Yeah, exactly.
So I'm going to do the Dexmed CRI, just, make
Would you have done that from the start?
Probably.
Oh,
I love a
okay.
Dexmed CRI. It's like
Yeah.
some of the best quality anesthesia that money can buy.
Yeah.
It's true.
It blocks that sympathetic tone, which is what we all want.
You more than anyone, Bailey.
I mean,
Now, the
if
most
my choice
important
was,
question.
like, let's say, am I going to do Dexmed and a tap versus an epidural?
Sure. Yeah, that's a great question.
Personally, I would do the tap and the CRI. Because I think the conferred risk to the patient, I mean, there are people, we're very, like, no big whoop-de-doo about epidurals, even though an epidural is a really great way to cause a pretty bad problem. So, but yeah, I think I would rather do the CRI and the tap block.
Agreed.
Probably because I will have less technique failure in that capacity.
Mm-hmm.
And I feel more confident that I am diffusely reaching the viscera in a reliable way than I might do with the epidural.
Yeah.
Okay.
Now the main question is, post-op, do you give a gabapentin?
I mean,
I give the gabapentin to myself so I can get out of this conversation. But yeah, no, now there are certain cases where I think that certain types of visceral pain may contribute to some degree of like neuropathic pain. And the one that I do think that they do respond to well clinically, and my hypothesis is related to the fact that it is because there has been sustained neuropathic nociceptive amplification, is blocked cats who've had a really large, when their bladder is so big that by the time like it actually is released, and then they pee blood for 3 days anyway because it's just been so distended. And I do think that contributes to some degree of like neuropathic pain. And so I think they respond well to gabapentin. Or I could just be being thrown under the bus by essentially like the fact that you're sedating them. And of course, the more you sedate post-op or post-procedural blocked cats, the less likely they are to reblock. So I haven't really teased that one out, but I will onboard gabapentin.
They're also super.
They're what?
Oh. I mean, if they're a block cat, they probably are an anxious cat to begin with. Like, yeah. Part of blocking is like essentially anxiety.
You know what cats are like? Like another cat walks by the window and they're like, "I'm gonna die."
Yeah.
So yeah, no.
Guess we're over. I now have to stop peeing.
But yeah, the cats who are still sort of having that like bloody pee a few days out, but not necessarily like they're not dysuric or stranguryc or what have you, but they're still, they're not eating quite as well, and they're maybe just, doing cat things like hiding, or they're like less interactive with the one person in the world that they like. Those ones, I think gabapentin may have an important indication, whether I'm right that that's because of neuropathic or whether it's because the sedation is conferring some anxiolytic capacity. I don't know, but either way, I'm helping them out somehow clinically, I think.
I've got a question about sympathetic arcs in cats. So when ACVS and ACVA combined together, there was a human anesthesiologist, and he was talking about like enhanced recovery after anesthesia pathways, like the ERAS pathways or whatever.
Yeah.
And he was discussing a patient under anesthesia and, responding to them and how we treat them, blah, blah. And he was like, if they have a sympathetic arc, which is what we're all talking about, he's like, I give them a beta blocker and I move on. And the entire room of anesthesiologists about shit their pants. Like collectively, I could smell it.
Yes, they do that in humans. If you have an increased heart rate, And they don't even think about whether it's pain or not. They don't care. They just give a beta blocker. That's it.
So that's where everyone's like, but it could be pain.
Dun dun
No, but
dun.
Yeah.
human medicine does not care as much about pain as we do. Like we've become so pathologically phobic that we're missing an iota of pain that we've probably gone to the point where we're over medicating a lot of patients for pain. And also in the
I think I
human
know someone on this call who maybe did a really good study about that. I cite that study all the time.
But also don't forget in humans, like they're super reluctant to give analgesia because they're so upregulated about the liability associated with opioid addiction.
Yeah.
Right?
Yeah.
Like you honestly, like you could literally fall from a building and have bones sticking out all over the place and they'll be like 2 mics per kg of fentanyl, take care. And you're like, wait,
Yeah.
what? Or you should take a
Yeah.
Tylenol. take a Tylenol every 8 hours. Yeah. And you're like, I don't think so. Like,
That's for sure. But the NSAIDs, a lot of people undervalue the value, like how good an NSAID is.
Oh my God.
pain.
Everyone should read that like huge meta-analyses that came out in like, I don't know, 2018, 2019 in people that was like, nearly, I think it was like nearly 100,000 people, and they were all on like chronic opioids for like chronic pain. And like, I think they didn't get any benefit, and most of the benefit was shown through the use of non-steroidals. So like, we need to argue for non-steroidals for everything.
I know, but that's a big argument, man, because like I've heard like internists actually say, I think that NSAIDs should be banned clinically, full stop. And I'm like,
That was a talk at AVA this year.
Right? Should we ban NSAIDs?
I think we should keep this for another podcast, though.
Yeah.
We're going.
I mean, I'm always a big fan of like anytime someone tells me something's not painful or like the degree of pain or whatever. And I'm like, well, no problem. I was like, well, let's just try it on you and you let me know how it goes. Like when people say things like, like ovarian hysterectomy is not as painful as I don't understand that whole thing of vet med, like spays aren't painful, but like we'll like analgesize the shit out of a splenectomy, which is an amputation of an organ. But for a hysterectomy, we're like, I'm going to give it butorphanol. And you're just like, what? Like if I were a human who had a hysterectomy and you gave me like a pat on the back for analgesia, I'd knock your teeth out. So I think that's wild, but I
agree with you.
Want to ban NSAIDs. I just think, no problem. Let's tell you what, you bend over.
I feel like we know our next
I'll put you
topic.
in the perineum with a 24 gauge needle. And if you don't react, I won't give this dog anything. Simple enough, right? If you don't react, I won't give this dog a lick of pain medication because obviously it's going to rock its socks. But like, I'm totally like, that's the most ridiculous thing I've ever heard. And I'm not an over like pain medicator, but like, I'm totally like, understand your physiology.
You got triggered so much during this episode, Tasha.
Probably because I just drank 3 glasses of champagne. Yeah, you came in on like low key beanie with your HOCM, which honestly I was like, oh, this is going to be a weird podcast because I have nothing left to say for the next 59 minutes. But here we are.
Yeah, I was like, cats and heart disease. Yuck. I just like to close my eyes and just like hope for the best.
Next recording is mine, and I'm going to do something wild. Like buckle up for marine mammals, gentlemen.
Christ. Okay.
Well, thank God the guy who wrote all the marine mammals book is named James Bailey. So I'll just get him on the blower and then he'll do my part.
You can phone a cousin and be like,
hey, James.
Jimmy. But yeah, no, my next topic is gonna be like wildly irritating. Yeah.
Oh my God.
Wild.
Camelot, cells, something like that.
All right. Well, thank you everybody for listening. I guess next time is Dr. Happy New Year. Next time is Dr. Happy New Year. Yay! She kept it for the end. Unbelievable.
I've got my nice tuxedo jacket on.
Yeah. Is that velvet, Bailey?
Yeah. It's green velvet with a shawl collar.
That's so cute.